Professor Marc Leone, who is the chair of the Department of Anesthesiology and Critical Care Medicine at the North Hospital in Marseille. He's very, very busy at the moment with the COVID-19 situation. So thank you very much, Marc, for joining us. He's an expert in sepsis and trauma in critically ill patients, and he's an active member of the French Society of Anesthesiology and Critical Care Medicine, and is also involved in the European Society of Anesthesiology and the European Society of Intensive Care Medicine. And Marc is going to talk about vancomycin use in Europe. Thank you, Marc.
Thank you, Claire. I'm sorry not to be with you, but as you said previously, that's very busy here, and thanks to COVID, I can't live here all the time without my need for apartment or car or anything else than my scrub. So I'm going to share my screen now. Up. Up. Is that fine with you? Do you have my screen, Claire?
Yes.
Yes, okay. So I have to talk about vancomycin, and I thank the organization committee and Claire especially for this topic. I don't feel very young to speak about this drug, this old drug, but that's life. I didn't put a slide for my conflict of interest, but I conflict of interest with Gilead, with Aspen, with MSD and Pfizer. I'm sorry for forgetting that. I will start with three nice picture, a picture of landscape of Island in Borneo, where Streptomyces orientalis was found for the first time, and vancomycin was extracted from this yeast. The second one is part of cake, of chocolate cake. I hope you like chocolate cake. And chocolate cake for me is Mississippi mud, and from Mississippi mud they extracted the compound 05865, and that was vancomycin, which was very impure and generate a lot of side effects like renal impairment, and this drug, this compound need to be purified before use, and that was a reason for the reputation of vancomycin to have so many side effects. And in fact, since the 80s, it's not extracted from this Mississippi mud, and the compound is now very pure. And for finish, a mountain bike picture, Vanquish from the background, backcountry, and vancomycin come from Vanquish, because with this drug you can vanquish your fight against gram-positive bacteria, and the FDA approved its use in 1958. So the use of vancomycin increased significantly in the 80s with the emergence of Staphylococcus aureus, and especially when they were MRSA, and few cases of Enterococcus, probably less in Europe and much more in the US, where the vancomycin has been used for agricultural reasons, and with lots of Enterococcus resistant to amoxicillin. So in Europe, we didn't know very well that, also it's not impossible, and we use a lot of Staphylococcus aureus for vancomycin for Staphylococcus aureus. There is a marginal use of oral form of vancomycin for Clostridium difficile treatment as local treatment for disinfection of the enteral tube. So what are the features of this drug? It's a very, very big drug. And you can see on the right of my screen that it is one of the largest antibiotic in the world, much more larger than peptides or ceftazidime. Vancomycin is around 500 Dalton. It is a big antibiotic which penetrates slowly in the tissue, and it is a very, very slow antibiotic due to this huge weight. So it is a slow mechanism of inhibition of peptidoglycan layer biosynthesis. This is like a zipper. The construction of the gram-positive wall is like a zipper, and vancomycin block this zipper by a mechanism of stopping transglycosylation. So it is an antibiotic with bactericidal activity, but it is a very slow bactericidal activity as compared with beta-lactams. And we need to use them for at least 2 days to obtain this bactericidal activity. So in general, if you have the choice between cephalosporin or beta-lactam and vancomycin, please use first beta-lactam instead of vancomycin, and that has been very well shown in study comparing for staphylococcus treatment the two family of drugs, and cephalosporin were very, very much more efficient, like ciprofloxacin 2. Most antibiotics are most efficient in terms of bactericidal activity than vancomycin. So that's a slow antibiotics working very well, but very slowly. As we saw previously with my previous speakers, this is a two-compartment models. I'm not an expert in this, so I'm not very comfortable, but when you give a loading dose, there is a bolus dose, there is a peak, and there is a decay. And the decay for vancomycin is around 6 to 12 hours. That's BT elimination. The elimination is done by kidney at 80%. So each time there is an acute kidney failure or impairment, you have a decreased elimination and a risk of increased concentration. The protein bonding is around 10 to 50%, so relatively low for an antibiotic. What is the best predictor for efficiency of vancomycin? As you know, for beta-lactam, for example, is probably time above MIC. MIC for minimal inhibitory concentration at most of the time 19%. And in this case, that doesn't work very well. You can use the peak related to MIC, like for aminoglycoside, and as you see, it is not really efficient. In this axis, you have the change in log CFU over 24 hours, and you see that is not really spectacular. And the best way to assess the efficiency of vancomycin is the relation between the area under the curve related to MIC. And this is the same thing that we use for fluoroquinolones. So this is the best predictor for for obtaining an efficient treatment when you use vancomycin. So we need to have some software, and previous speakers detailed that, to elaborate the best IUC on MIC ratio. So here it's much more easy to understand. You can look at your peak only, and the relation between the peak and the MIC, which is here. The concentration of your antibiotic is here, and the time is on x-axis. And if you have only the peaks, that works well for aminoglycosides. So you need to provide high doses and single dose every day. For beta-lactam, you need to have most of time your concentration above the MIC, above 4 to 10 times the MIC. And for vancomycin, which is our interest today, is the relation between this area under the curve and the MIC, which determines the best efficiency. And this is not only theoretical concept, because when we assessed a cohort of patients with septic shock, you can see that when this ratio is below 451, the probability of survival is 20%, and when the ratio is above 578, the probability of survival is 80%. That's really surprising for me. These results, to be very honest, are surprising. That's really surprising to have such differences, but that's this ratio, and of course, it is for us clinicians, the most important issue is to improve the survival of our patient. And in these models, it seems that there is a real impact of the modelization on the outcome of our patients. For IDI guidelines, so North American Society, vancomycin should be used as first line for MRSA infections, and for several North American Society of pharmacists, the target vancomycin through concentration should be at 10 milligrams per liter to avoid development of resistant strain, and 15 to 20 to improve tissue penetration. And that's the guidelines which are available now for more than 10 years. So in terms of administration, what should we do? Bolus, continuous infusion, or both? And I assume that the European way, the European vision of use is bolus, a loading dose, and a continuous infusion, and the rest of the world use repeated or intermittent bolus instead of that. When I say rest of the world, is very often North America. I don't really know in Australia or New Zealand. I think they perform the best, of course. So what are the different models? The intermittent use is loading dose and the prolonged decay, covering around 6 to 12 hours, depending on renal function most of the time. And you can re-administrate a second loading dose, and like this for a long duration. So you have your area under the curve, but you are here, you can lose some efficiency at this time. And when you use a continuous infusion, you can have a good time above the MIC, but it is a slow process to reach your target concentration. The target concentration is the concentration at which the drug is efficient to decrease the number of bacteria, in fact. And probably the best way to do is to use a combination of first loading dose and to launch a continuous infusion. That's a model which is used very often in anesthesia for sedation at the operating rooms. Probably the best model should be based on propofol models, for example, in the OR, and that's the same thing. And we did that. There is 20 years ago with a friend of mine, Xavier Vivian, in North Hospital, and using these models, you have rapid efficiency and a prolonged efficiency too. So you combine the advantage of the two methods. Of course, you do not re-administrate a second loading dose, except if your concentration is not in the target. So basically, the model are either intermittent administration using bolus of 15 to 20 milligram per kilo, 2 to 3 times a day, looking for through levels ranging from 15 to 20 milligram per kilo, and starting the monitoring before the fourth dose. As a alternative models is to use a bolus of 25 to 30 milligram per kilo. Please use 2 hours to administrate this bolus. It's very important. There is a risk of Redman syndrome if you administrate too fast your vancomycin loading dose. And then you use a continuous infusion from 30 to 60 milligram per kilo per day, probably 30 if it is pneumonia, 60 if it is a CSF infection, and in 2000 we show in my department here. That was one of my first publication. That's in CSF infection. We have to use up to 60 milligram per kilo per day to be in the good target. So there is some good study, a randomized clinical trial comparing the two methods, the continuous infusion with a target at 20-30 and intermittent with target between 15 and 20, which are the recommendation, the standard recommendation. And as you can see, the time to achieve the goal serum concentration, and it is very important, especially for patients with septic shock, is critical, is shorter in the patient receiving continuous infusion, and it's very the difference is striking. As you can see, it's striking. It's in days here, so these 2 days is pretty long with continuous infusion. It's really long, but it's longer than 3 days for intermittent administration. And the time within the therapeutic range, the time of efficiency of your drug during the world time of your administration is only above 50% when you use a continuous infusion and less than 40% when you use intermittent bolus. That's very, very low, 55% versus 34%. So basically, the lessons is that it's a slow antibiotic and that the therapeutic range are achieved only in 45% of patients in the best conditions. So that puts several questions, and do not use intermittent administrations. In addition, you use less total dose with continuous infusion, and the cost per patient is lower when you use continuous infusion instead of intermittent administration. There's another study in trauma patients with suspected ventilatory associated pneumonia. The serum level were much higher using continuous infusion instead of intermittent bolus. As you can see, 9 microgram per milliliter with intermittent bolus and 20 for continuous infusion, and the therapeutic range once again are achieved in nearly 60% of patients with continuous infusion, like in the previous study, and only 7% of patients with intermittent administration. In addition, there is much more renal toxicity when you use intermittent administration. There is no effect, and in this study there was no effect on mortality. So my personal choice is the loading dose around 25-30 microgram per kilo and a continuous infusion. The risk with vancomycin is renal toxicity. There is also a risk like neutropenia or something like this, but it's less frequent. And the renal toxicity is found in patients with high concentration, not for the first loading dose, and it's a very important message. The first loading dose, you don't have to care with the risk toxicity, and when you compare 15 to 30 milligram per kilo in ED patient, the renal risk is the difference is non-significant between the two drugs, the two dosage. But when you use high dosage, as you can see on the right, above 20 milligram per liter, you increase the risk of renal toxicity, especially when you use other nephrotoxics like peptides, for example. There is a kind of synergy between the drugs, and you increase the risk of renal failure in your patients. When you use high serum levels in a large cohort of patients and a long duration, more than 5 days of vancomycin, and you define your renal failure by a 50% increase of serum creatinine on 2 consecutive days, the overall incidence of renal failure is 9%, and the recovery occurs 1 week after stopping the dose. The factor associated with adequate levels in a paper from Jan de Waal from Ghent, where older age, female sex, high serum creatinine, low body temperature, and the use of loading dose. And as you can see, when you use a loading dose above 15 milligram per kilo, you reach the target much more frequently than with a low loading dose. So in practice, is vancomycin so bad? But I will close my presentation with that. When you look at large publication, large randomized clinical trial, finally, the side effects are not so frequent with vancomycin and not so apparent when you compare the two groups in terms of, for example, renal failure. You increase a little bit, that's true, but the other effects are not so pregnant. And in this study, which is very similar study, there is no information on survival, duration of mechanical ventilation, duration of ICU stay. So we can think that they were similar, in fact, and that vancomycin is not so bad. Same thing for complicated skin infections. in this paper with similar side effects, except for renal failure, which occur more frequently in the patient treated with vancomycin. So my take-home message: use vancomycin in Staphylococcus aureus or other with an MIC below 1 microgram per liter. Use, if you can, have the modelization of the ratio between IUC and MIC. That's a slow antibiotic, so be careful with that. We need time. There is a renal failure that should be expected in around 10% of patients. Use a large loading dose, which is independent of renal function, and a continuous infusion, and you perform through serum concentration to adapt your best dosage. And to conclude this talk, in my opinion, today there is some alternative to vancomycin, and I don't know why. I don't know if it is a real good message, but I feel that we should use this alternative in first line in the most severe patient, because vancomycin is a very good antibiotic, like a very old car. In Morocco, you can see very old car and they work, but there is better cars now, and there is better antibiotics in terms of kinetics, and I think we should use them in priority in the more severe patient. Thank you for your attention.
Thank you, Marc, for this excellent presentation. I hope you convince the audience to use a continuous infusion with loading dose rather than an intermittent infusion for vancomycin. Maybe we'll have some questions from the audience. I have a question for you. So you use a loading dose independently of the renal function of your patients, but then for patients with acute kidney injury, how do you adjust the maintenance dose? Do you use a nomogram or
in practice, we don't use a nomogram. We use a actually, in our RCU today, when a patient has a renal impairment, we don't use vancomycin because really I don't understand why using such a complex antibiotic instead of other alternatives, which are as efficient, perhaps more efficient, and much simpler to use. So today, to be transparent, I don't understand the benefit to still use a vancomycin in patients with severe renal impairment. There is some alternative which are not very expensive, which are not at high risk, with less side effects. And today in my CU, clearly, if a patient has needs vancomycin or gram-positive treatment, we suggest as first line to use an alternative, linezolid or daptomycin, to be clear.
Okay, so you use less and less vancomycin for your critically ill patients.
Yeah.
Okay.
Yeah, because that's slow, because that's difficult. You can use nomogram, you can use modelization, you can use several dosage, but somewhere there is a risk for your patient of renal impairment and renal worsening, especially those with an acute renal failure. And in those patients, I don't see the benefit to still use this drug.
Okay, thank you. Thank you, Marc.